I am Dr. Sanket Mehta, Director of Specialty Surgical Oncology Hospital and Research Center. I am a cancer surgeon and I've received my training from Tata Memorial Hospital for 4.5 years, following which I was in Korea for 4 months, France for 1.5 years, and I've had various stints at United States, Italy, and again in France. The whole idea being to specialize in my subject of interest, which is GI and Gynac oncology. This by itself is a very vast field. Gone are the days when a cancer surgeon can cater to everything from head to toe. Now we are in the era of precision medicine and precision surgery, and it makes complete sense for a surgeon to specialize in a specific topic so that he can deliver better results for the patients. My topic of interest is GI and Gynac oncology, in particular treatment of advanced malignancies within the abdomen. We started doing Cytoreductive Surgery and HIPEC way back in 2011 when this concept was unheard of in India. Since then we have built a very robust program of treating peritoneal surface malignancies with Cytoreductive Surgery and HIPEC, and we have performed more than 700 of these procedures and more than 1500 cytoreductive surgeries. We also perform a lot of liver surgeries using intraoperative ultrasound guidance, which encompasses patients who have metastasis to the liver or primary tumors of the liver. And we treat all type of gynac malignancies. This also includes performing minimal access or minimal invasive surgery, so laparoscopic colorectal surgery, laparoscopic upper GI surgery, laparoscopic gynac malignancy surgeries, robotic surgeries, etc. Over the last 10 years, we have developed a good fellowship program where we have newly trained cancer surgeons working with us, specializing in this field. We have a proctorship and mentorship program to help other surgeons learn the skill set. And so academically, it was very satisfying journey till now. But what was troubling me was the fact that for every patient that I could treat in a corporate hospital, there were at least 3 others who could not afford the treatment in these corporate hospitals. And that somewhere was hurting me and pinching me morally as well as ethically, that I was not able to deliver or make an impact where it was needed most. Over the few years, I also met with several like-minded people and people who had the exact same grouse about not being able to cater to all classes of the society. And at some point, it became incumbent that we should address this issue, and hence specialty surgical oncology. So, 2 specific surgeries I'll talk about. One is cytoreductive surgery and HIPEC. Essentially, these are diseases which are arising either from the GI tract or gynac malignancies, or very rarely other malignancies which are spread to the peritoneum. Now, what is peritoneum? Peritoneum is the membrane that lines the inner aspect of the abdominal cavity and envelopes all the organs within the abdominal cavity. Its main function is barrier and lubrication. Just to give a very simple analogy, it's like secretes a thin fluid like saliva, which lubricates all the different organs and helps them function properly. Peritoneal fluid is absorbed by certain areas of the abdomen, including what we call as the omentum, which is a pad of fat, and certain areas within the peritoneal cavity. When a malignancy spreads to the peritoneum, these are free cancer cells that deposit on the peritoneum in either areas of stasis or in areas of absorption, or by direct contact, and then start growing and affecting other areas of the peritoneal cavity by shedding cells over the into the peritoneal fluid. This is a very tricky situation to deal with because peritoneum has an inherent barrier function. So chemotherapy that is given through the bloodstream does not reach in adequate quantities inside the peritoneal cavity. Also, peritoneum receives only 2% of the cardiac output. That is 2% of the entire blood pumped by the heart every minute. And hence, giving chemotherapy to tackle this disease is a very inefficient way of treating this disease. You will get a lot of side effects of the IV chemotherapy and very little of the chemotherapy actually reaching the target. And which is why IV chemotherapy or systemic chemotherapy is not efficient in treating peritoneal malignancies. At the same time, when you do a surgery, you are only treating gross visible disease here. But there is a microscopic disease that is spread all across the peritoneal surface and the visceral peritoneal surface, and which is why this microscopic component needs to be tackled by another form of treatment, and that is the HIPEC. HIPEC is an acronym that stands for hyperthermic intraperitoneal chemotherapy. So during the surgery, we give a chemotherapy bath which is heated to 42 to 43 degrees Celsius, which is extremely efficient in eradicating microscopic disease. And that is because the mechanism of action of this heated chemotherapy is completely different from the IV chemotherapy. IV chemotherapy enters the cells by the bloodstream and destroys the cells by what we call as cytotoxicity. Whereas intraperitoneal chemotherapy, which is heated, enters the cells by plain simple diffusion, and it prevents the cells from multiplying by a process called as apoptosis. And the combination of an aggressive surgery with HIPEC is what can give good long-term survival and a potential chance for cure for patients of peritoneal surface malignancies. The other topic that is extremely dear to me and where we have done a lot of good work is liver surgery. So when the disease is involving the liver, either a primary tumor or metastasis, that is spread of GI or malignancies to the liver, the best form of treatment is surgery, where we can remove the entire liver disease. However, liver has got a limited capacity to regenerate, and also patients who have got primary tumors of the liver often have underlying liver disease which leads to chronic parenchymal liver dysfunction or frank cirrhosis. In these patients, there is a very challenging limitation to the amount of liver that can be removed. So how do you address this issue is by using a very high-end technique called as intraoperative ultrasound guided surgery, where we use the precise localization of various blood vessels and the biliary tree within the liver and its relation with the tumor, and excise the tumor while preserving this entire blood supply and venous drainage of the liver. This helps the liver to regenerate after the surgery, whatever volume has been lost. With this type of treatment, we are preventing post-operative liver failure, and we are increasingly treating more and more complex spread of disease within the liver.